is Dr. Eman Gamal, a pathology resident at Theodore Belhar's Research Institute, and her presentation is entitled The Ugly Face of an Innocent-Looking Tumor. This presentation is under supervision of Professor Dr. Noha Abdulhafiz Helmi, a professor of pathology and head of pathology department at Medical Research Center of Excellence in the National Research Center.
Good morning. At first, I have to say that it is an honor for me to participate in this great event. Thank you, Dr. Muhammad Kamal, for giving me this opportunity. So let's start. The ugly face of an innocent-looking tumor is a case presentation presented by me, Eman Gamal Muhammad Gamal, specialist of pathology at Theodore Belhar's Research Institute, and under supervision of Professor Dr. Noha Abdulhafiz Helmi, Professor of Pathology at National Research Center. Our case is female patient 53 years old, presented with abdominal pain and abdominal mass. MRI with contrast showed an exophytic right renal mass. The patient underwent radical nephrectomy and the specimen was sent to our lab. Gross examination of the radical nephrectomy specimen revealed a well-circumscribed mass involving the lower half of the right kidney, measured 11 cm in the maximal dimension, and the other two dimensions were 9 and 8.5 cm. Cut section of the mass was variegated yellowish-white with focal hemorrhagic and cystified areas. Perinephric fat, renal sinus fat, and the pelvic calyceal system were free of the tumor. Under the microscope, the tumor was well circumscribed and composed of areas showing tubular differentiation with luminal mucinous material together with abrupt transition. As we see here, tumor cells show a moderate amount of eosinophilic cytoplasm and round to oval nuclei with minimal pleomorphism. There is focal mucinous stroma and spindle cells arranged in cords, as we see here. As we see here, the tubules, packed tubules and myxoid stroma. And here the myxoid stroma is clear and the spindle-shaped cells are present here. So these three findings led us to the diagnosis. The three findings, or the three main findings we found again, are the tubules with plant-looking lining, epithelium, and spindle cells areas together with myxoid stroma led us to a provisional diagnosis, which is mucinous tubular and spindle cell renal carcinoma. But examination of the rest of the slides revealed hypercellular areas of spindle cells and the tubules, and with high complications, there are anaplastic changes detected in the spindle cell component and the tubular component formed of moderate to marked pleomorphism, hyperchromatic nuclei with nuclear membrane irregularities, and increased mitotic figures. As we see here, increased mitotic figures, and the pleomorphism is moderate and marked. And here, increased cellularity of the spindle-shaped cells areas. Immunohistochemistry was performed and the results are as the following. Cytokeratin 7 was positive, CD10 was negative, racemase was diffusely positive, Ki67 was low, about 10%. So all these findings led us to the final diagnosis, which is mucinous tubular and spindle cell renal carcinoma with evidence of high-grade transformation. These are two case reports of the same tumor. The last recent one was published in October 2024, which was high-grade mucinous tubular and spindle cell carcinoma of the kidney in a patient on hemodialysis. So, about review of literature, mucinous tubular and spindle cell renal carcinoma was first included in the 2004 edition of the World Health Organization classification of RCCs, and in the recent update has gained importance owing to prognostic and therapeutic differences. According to the WHO 2016, this tumor accounts for less than 1% of all renal tumors. It's a tumor primarily of adulthood with a mean age of 58 years, range from 13 to 81 years. Mucinous tubular and spindle cell renal carcinoma shows a female predominance with a female to male ratio of 3:1. About the clinical features, the majority of the tumors are incidentally detected on abdominal imaging for other unrelated reasons. However, some may present with hematuria, flank pain, and a palpable abdominal mass. On CT imaging, it typically presents as a well-demarcated exophytic or spherical renal mass and shows an expansile growth pattern. About the macroscopic features, these tumors are well circumscribed and solid with homogeneous tan, gray, pink, or pale yellow cut surface. Tumor size ranges from less than 1 cm to more than 18 cm in diameter, with most tumors being 2 to 4 cm. Areas of hemorrhage and necrosis are unusual. And about the microscopic features, the tumor is characterized by a mixture of tubular and spindle cell components separated by variable amounts of mucinous stroma. The tubules are round, ovoid, or elongated with a collapsed central lumen. They are usually tightly packed and sometimes merge into cord-like structures or even form a solid growth pattern. Some tumors, the spindle cell areas can be the dominant component. Extracellular mucinous myxoid matrix are usually abundant in the majority of the cases, and sometimes these mucinous collections may appear as numerous small vacuoles partially obscuring the MTSRCC architecture and mimicking clear cells. Also called mucin-poor pattern of MTSRCC has recently been described where there is little or no extracellular mucin. Tumor cells are usually bland appearing with scant pale to slightly eosinophilic cytoplasm. The nuclei are round, uniform, and display low nuclear grade features with evenly dispersed chromatin and inconspicuous nuclei corresponding to Fermat nuclear grade 2. Mitosis and necrosis are rare. Sarcomatoid differentiation characterized by high-grade spindle cell proliferation with marked cytologic atypia, tumor necrosis, and increased mitotic activity, as we see in our case. Other stromal changes that can be also seen include aggregations of foamy macrophages, cuffing infiltrations of lymphocytic cells surrounding the tumor nests, deposition of small samoma bodies, and heterotopic bone formation. About immunohistochemistry, the neoplastic cells of both the tubules and spindle cells are positive for PAX2/8, low molecular weight cytokeratin such as cytokeratin 8/18, cytokeratin 19, and cytokeratin 7, epithelial membrane antigen, alpha-methyl-CoA racemase, and E-cadherin. Staining for vimentin and high molecular weight cytokeratin show variable expression. RCC marker such as CD10 and CD15 are often negative but occasionally be positive, while staining for carbonic anhydrase P63, cytokeratin 20, GATA3, and SMA are typically negative. About the pathophysiology and molecular features, these tumors have a phenotyping expression pattern similar to the loop of Henle region of normal nephrons, hypopathway dysregulation with increased nuclear YAP1 protein expression, CDKN2A or CDKN2P deletion may be present in high-grade tumor. FISH shows no VHL deletions, moderate to high expression of VSTM2A via RNA in situ hybridization. About prognosis and management, these tumors have indolent behavior. rarely associated with distant metastasis and rapid tumor proliferation and expansion. In case of sarcomatoid differentiation only, surgical excision is the mainstay of treatment. Selected cases received adjuvant therapy with tyrosine kinase inhibitors and PD-L1 inhibitors. So, take-home message: proper and adequate sampling along with careful microscopic examination is critical to avoid being deceived by the innocent face of the mucinous tubular spindle cell renal carcinoma. Failure to do so may result in missing its ugly face represented by foci of high-grade sarcomatoid differentiation which exhibits aggressive behavior. Thank you.